Presentation number 2, brain neoplasms, prepared by Prof. Sharaf and revised by Prof. Rami Edward. We'll talk of some of the neuroepithelial tumors. The alternative name is intraaxial glial tumors. All of them are called gliomas. All of them are lacking a capsule. Gliomas are 50% of the primary CNS neoplasms, and 70% of these gliomas are astrocytomas. The most common are two astrocytomas, as they are 70%, and also oligodendrogliomas, which form a considerable percentage. These are graded according to the cellularity, meaningly the presence of mitotic activity and polymorphism, the presence of necrosis, and the rate of growth or rate of proliferation. Classification. This is a classification made by the WHO. As we said, all glial tumors lack a capsule. We have the first group, the localized astrocytomas, and from the name localized, that all are well circumscribed. They have a cyst with sometimes enhancing nodule or enhancing solid part, but this enhancement is minimal and confined, and there is no or minimal edema. So we have well circumscribed lesion, which could be cystic with minimal enhancement except for a nodule, and minimal or absent edema. The second group are the diffuse astrocytomas, means the infiltrating group, because the first group is localized, the second group is infiltrating. We have three examples: the low-grade astrocytoma, anaplastic astrocytoma, and the glioblastoma multiforme. The differences are as follows. Number one, about the being circumscribed or not. Number two, the pattern of enhancement. And number three, the pattern of edema around. All of them are not circumscribed. All of them are diffuse infiltrating. So this one is out of question. The second thing is enhancement. Low-grade astrocytomas, being low-grade, they show no enhancement, while anaplastic astrocytomas show heterogeneous enhancement, and the glioblastoma multiforme show heterogeneous again enhancement, sometimes with ring heterogeneous or ring enhancement. So you can exclude the low grade because it is not circumscribed. This is infiltrative, different from the localized form of astrocytomas. And number two, that it has it shows no enhancement, but there is edema. In anaplastic astrocytoma, there is heterogeneous enhancement and of course edema. In glioblastoma multiforme, the name implies that there are a wide range of changes, including necrosis, mass effect, mass, cyst changes, hemorrhage, and of course the two famous heterogeneous or ring enhancement and the presence of edema. Glioblastoma multiforme affects older age. The pilocytic astrocytomas are most common pediatric CNS tumors, and we said that they are 70% of the gliomas, and in the cerebellum the range is high. It reaches up to 60%. 2/3 of cases present as cyst, 1/3 present as solid mass. If it is a cyst, there will be a nodule, and if there is a nodule, this nodule may show minimal enhancement or sometimes ring enhancement. but in all cases it is a well-localized tumor and there is no edema or minimal edema. Calcifications, of course, so long it is low grade, it is not growing rapidly, it allows for dystrophic calcification in 20% of cases. This is an example of pilocytic astrocytoma occur posteriorly, and as we just mentioned that 60% occur posterior in the cerebellum, of course associated with hydrocephalus, and you can see clearly the enhancing nodules inside. Another cerebellar astrocytoma, pilocytic type, we can see the ring enhancement, and you can see some central cystic changes and degeneration. Another one with calcification. This is centered on the corpus callosum. There is calcific rim, there is cystic change, and these are different from other causes of corpus callosum tumors, that there is no edema at all, and they are well circumscribed. Well circumscribed, and there is no edema. Here is another cyst centered at the region of the suprasellar cistern. Of course, we should consider also craniopharyngioma, and here it is related to the anterior cerebral artery and internal carotid, as well as the infundibular stalk of the pituitary. The differential, as we said, is craniopharyngioma. Something well defined, something cystic, showing partial enhancement of the nodule or minimal enhancement, no edema surrounding. These are the characters of the more benign form of gliomas, which is the pilocytic astrocytoma. Another case, but here there are two differences. One difference is that the enhancement is extensive a little bit, and the edema is there. So you cannot tell that this is simple astrocytoma, because there is edema, and there is cyst, and there is irregularity, and there, of course, element of necrosis resulting in the irregular narrow cavity, irregular cystic cavity, and thus we should consider also glioblastoma, more aggressive form like glioblastoma multiforme. Of course, it is not a low-grade glioma, because in low-grade glioma there is no enhancement, and it could be aggressive astrocytoma, but the presence of more than one pattern point more to glioblastoma multiforme. The presence of cyst, the presence of a mass, the presence of nodule, irregular, the presence of irregular enhancement, of ring enhancement, and the presence of extensive edema. Here is a large tumor seen subepidermal. It's appearing as a solid mass with obliteration of the left foramen of Monroe, of the right foramen of Monroe. I think the true is left foramen Monroe, with definite obstruction of the posterior aspects of both lateral ventricles as well as the right frontal horn. Hydrocephalic changes with compression of the left lateral frontal horn. Now, if you look to the first one on the left, there are this is a higher level showing multiple tubers multiple tumors occurring in tuberous sclerosis. And of course we know that there is association between tuberous sclerosis and subependymal small astrocytoma appearing as a solid mass. Solid astrocytomas occur in 1/3 of cases. 2/3 of cases are showing as cyst with nodule, and 60% of cases are posterior in the region of the cerebellum. All cases are well circumscribed with no edema. All cases show minimal enhancement or nodular enhancement of the tumor. Association with tuberous sclerosis and multiple tumors is well recognized. Here we have a different story, a little bit different, that the lesion cannot be drawn, cannot be delineated. It is rather infiltrating, not circumscribed, but at the same time it is not enhancing, as is seen on the right side in the contrast enhanced T1 weighted image. And this is resting on the tentorium. This is a typical form of low-grade astrocytoma, being not circumscribed, that is infiltrating, being non-enhancing, and there is edema and there is mass. Low-grade astrocytoma. Low-grade astrocytoma is at the right temporal lobe. Here again there is no enhancement noted in the T1 weighted images with contrast. The image on the right side, there is no enhancement, and this is characteristic of a low-grade astrocytoma. There is no nodule to be enhanced, there is no solid component to be enhanced, there is no irregular ring to be enhanced as in astrocytomas of the aggressive type or glioblastoma multiforme. There is no enhancement in this group of low-grade astrocytomas. Now this one is another low-grade astrocytoma appearing as low intensity in T1, high intensity in T2, hyper T2, hypo T1, and again without contrast enhancement. Low-grade astrocytoma. Third, another lesion where the occipital or the posterior horn of the left lateral ventricle is pushed forward and attenuated and is replaced with an infiltrating process, and the infiltrating process is showing no enhancement in T1 weighted images. The one on the left side, there is no enhancement, and it is a diffuse lesion. In the CT you can hardly see it. Coming to the anaplastic form of astrocytomas, where we have invasion, it's not circumscribed, and we have irregular enhancement as well, of course with edema. So we have the three. You have the loss of circumscription, I mean invasion, it's an invading process, and showing heterogeneous enhancement. In contrast to the low-grade type, where there is no contrast is seen. These group of lesions are infiltrating, and they are associated usually with edema, anaplastic astrocytoma. Now, how can we describe this? There is a tumor, there is a process going on at the left temporal region and attenuating the left lateral ventricle. It is seen in this CT scan with minimal contrast inside, intralesional minimal contrast is seen, but the margin is definitely ill-defined and infiltrative. So you can exclude safely the pilocytic astrocytoma, and you can exclude the glioblastoma multiforme, since you don't have more than one pattern, it's only solid mass which is ill-defined, but it is showing contrast enhancement intralesional. Intralesional or irregular contrast enhancement usually appear in cases of aggressive type of anaplastic carcinoma, but if low grade, it would show no contrast enhancement. T1 weighted image on the right side up, and T1 weighted image with contrast here in the middle are showing again the intralesional contrast enhancement, and of course you can detect that the apparent mass is smaller, more confined than the extensive edema surrounding, and here there is no intralesional restriction, So this is a case again of aggressive type of astrocytoma. Thank you.